And so I would like to thank Dan Lackland and Don DePet for your kind invitation to come here. And I was so impressed with the invitation that I brought my wife, and we're going to spend a few extra days.
Smartly ended.
Thank you. So my task is to talk about blood pressure treatment guidelines for the Southern patient. And I'll begin by saying that the treatment guidelines are exactly the same for any patient as they are for the Southern patient. And that's the last time you're going to hear anything about the South. Unfortunately, I have nothing to disclose. Now, I'm going to talk about the principal recommendations of the 2017 ACC-AHA hypertension guideline and some of the reasoning behind the principal recommendations. It has been described as a Bible of hypertension, and I can't possibly cover everything. So the big things are, first of all, the new blood pressure classification. And this is summarized on this slide. And so this shows systolic and diastolic blood pressure on the left. And then the 2003 JNC7 classification and the 2017 classification. So as you probably know, normal blood pressure is exactly the same in the two guidelines. But where we began to deviate was in the pre-hypertension area covered by JNC7 that spanned a large blood pressure range from 120 to 139 over 80 to 89. And we felt that the term pre-hypertension did not convey enough of the risk of these patients. So we abandoned that term, and we substituted two terms. The first one was elevated blood pressure for the lower tier, 120, 129 over less than 80. And then for the upper tier, 130, 139 over 80 to 89, we felt that the risk was sufficient to name that stage 1 hypertension. And so the old stage 1 hypertension in the JNC7 was 140, 159 over 90 to 99. And that and all other blood pressures above 140 over 90 moved to what we call stage 2 hypertension. Now, there was a stage 3 hypertension in the JNC7. But we decided, and I think Bill Cushman was important in having us look at that, to name only stage 2 hypertension because at the higher blood pressure levels, we're making the same exact recommendations for treatment as we were for these lower blood pressure levels. So in our guideline, we have normal elevated blood pressure, and then stage 1 and stage 2. And apropos of the last presentations, we insist on an average of 2 careful blood pressure measurements on at least 2 different occasions to make the diagnosis of hypertension. Now, my guideline chair, Paul Welton, is in the audience, and he will immediately correct me, hopefully, if I make a mistake. So the rationale for recategorization is in 3 parts. The first part is observational data related to the association of blood pressure and cardiovascular risk. The second is randomized trials of lifestyle modification to lower blood pressure, which all show highly significant differences in blood pressure control with a variety of lifestyle modifications. And the third is an analysis of antihypertensive medication efficacy, lower versus standard blood pressure to prevent cardiovascular disease. And I'm going to show you examples of all of these that were used in making our recommendations. So this is the quite familiar to most of you Lewington analysis published just before JNC 7. And this shows that blood pressure is continuously related to the risk of a fatal stroke or ischemic heart disease, and also non-cardiac vascular disease, down to a blood pressure of 115/75. Pretty impressive. And we also know from these studies that an increase of 20 millimeters systolic or 10 diastolic doubles the risk of a cardiovascular event. So the risk is high. But let's look at the risk of different blood pressure categories, and these are systolic categories shown here on the x-axis. And we're looking at a blood pressure of 130 to 139 in this category right here in the yellow. There is an approximate twofold increase in cardiovascular disease risk and mortality risk compared to normal. And then if we look at the blood pressure distribution by prevalence, we see that the prevalence rate is about 23% among all of the blood pressure distributions that are shown on this axis. So it's a highly prevalent problem with increased risk. And then here we show that about 20% or a little more than 20% of blood pressure risk is represented in this category of systolic blood pressure 130, 139. So then moving on to lifestyle modification, and Mike Moore actually constructed this little pyramid. The message is that the cornerstone of the guideline is lifestyle modification. Now, how we're going to implement that in clinical practice in the United States is a big issue. But lifestyle modification has been shown to be efficacious. As shown here in the left-hand column, you have various lifestyle modifications, and you have the blood pressure lowering that one would expect in a hypertensive and normotensive individual shown on the right. My pointer's about gone. What we can see here is that weight loss, you can expect about 1 millimeter of mercury reduction for every kilogram reduction in body weight. And the healthy diet, and we're recommending the DASH diet, can result or usually results in an approximate 11 millimeter mercury reduction in pressure. And then reduced intake of dietary sodium, at least 1 gram per day reduction will yield a reduction in blood pressure of 5 to 6 millimeters. And then an increased intake of potassium, especially in dietary foodstuffs, will lower the blood pressure by 4 to 5 millimeters of mercury in a hypertensive patient. And these are all generally additive. There are some exceptions, but in general, these are all additive, so if you combine them, they will lower the blood pressure even further. And I'd like to point out that these are recommendation level 1, level of evidence A. And then physical activity and moderation of alcohol will also lower blood pressure, as shown in the columns. So I think in the United States, we need to develop mechanisms in our practices, and perhaps, or likely with some help from governmental agencies and perhaps commercial agencies, to engage in lifestyle counseling in the office. So the next big change in the guideline, and these are all relatively large changes, is the blood pressure threshold for initiation of drug treatment. And here is the recommendation. And with an evidence level of A, we're recommending the use of blood pressure lowering medications in the secondary prevention of cardiovascular disease in people who already have established cardiovascular disease at the threshold of 130/80. So that's a drop in the threshold of about 10 millimeters of mercury from JNC7. And we're also recommending primary prevention for those with increased atherosclerotic cardiovascular disease risk. And this was a new departure, although it had been used in guidelines in Europe in the past. And then for people with low cardiovascular disease risk, ASCVD risk scores less than 10%, we moved up to a threshold of 140/90 to begin initiating antihypertensive drug therapy. So the way we are recommending to estimate cardiovascular risk has really not been done before, but is based on the 10-year risk of ASCVD by the pooled cohort equations. And the basis for these are shown here. They can all be plugged in with relative efficiency into an app and calculated. They can be done by the public as well as by the physician or other health caregivers in the office. And these are validated for adults between 40 and 79 years of age, and outside that range would have to be interpolated. So the online availability of this risk score system and its app are shown here. Now, why do we recommend assessing the cardiovascular risk score? And the reason we do is that risk is related to the efficacy to prevent cardiovascular events by lowering blood pressure. As shown on this slide, and my pointer has died completely, on the axis going this way is increasing risk, and the axis going this way is systolic blood pressure reduction. And as you can see, for any systolic blood pressure reduction, you get, thank you, a better estimate. For every systolic blood pressure reduction category, and this one has died as well. Maybe I'm. There we go. Good. You can see that the number of events prevented goes up as the global 5-year atherosclerotic cardiovascular disease risk goes up. So this slide just summarized the benefits of doing it this way, and that is that treatment is focused on the patients that are most likely to have events, that more cardiovascular events are prevented, and that a large absolute cardiovascular risk reduction with treatment is obtained, a lower number needed to treat to prevent one event, more quality-adjusted life years saved, and a lower cost of care. And so these are, I think, major reasons to use risk in assessment of treatment decisions. Now, the next major category that we changed is the blood pressure target for drug therapy. And our recommended target is the same, whether you have cardiovascular disease or a high cardiovascular disease risk or a low cardiovascular disease risk. The only difference is the level of evidence is slightly different. But we felt that we should have one target to make it simple and to give the best chance for cardiovascular disease event prevention. And so the target is less than 130/80 in both cases. So again, once drug therapy is started, the same target is recommended. Now, our evidence for this includes a lot of randomized clinical trials and meta-analysis of these trials that was provided within a couple or 3 years of the Guideline publication. This is an example of one of them, which compares blood pressure lowering stratified by the achieved systolic blood pressure target by Tomopoulos, published in 2016. And this slide shows that for stroke and for cardiovascular death and all-cause mortality, there was a significant difference as one ratcheted down the blood pressure, and even comparing greater than 130 to less than 130 systolic. And this is a sequential meta-analysis of randomized clinical trials, beginning, if you're interested in history, with the HOT trial in 1998 and going all the way through to 2015, and showing a significant benefit in the risk of myocardial infarction and also in the risk of stroke. And then perhaps the most compelling evidence is from BUNDY. And this is a network meta-analysis comparing achieved systolic pressures in various trials, the size of the trials represented by the width of the circles and bars. And in that analysis, there is a clear-cut result in these randomized comparisons in which progressive reduction in cardiovascular disease risk was present at lower levels of achieved blood pressure. And in this meta-analysis, the best blood pressure was 120 to 124. And this shows the rise in the hazard ratio, the lowering of the hazard ratio, comparing reduction in blood pressure from 120 to 124 to higher blood pressures. And this was true for stroke and coronary disease and all-cause mortality, as well as major cardiovascular events, and was similar if you took out the results of SPRINT. So this is a summary of our recommendation. You don't start antihypertensive therapy for normal or elevated blood pressure. If you start antihypertensive therapy, the target is always the same, that is less than 130 systolic or 80 diastolic, and you're likely to do that in the stage 1 hypertension category, in which the risk of cardiovascular disease is elevated. But for elderly patients, we only use a target of less than 130. Now, I want to cover 2 topics. Bill Cushman is going to cover diabetes, but these are comorbidities that one is likely to find in a hypertensive patient. And for chronic kidney disease, our recommendation is the same. That is initiating at 130 over 80 or higher, and the target being less than 130 over 80. Chronic kidney disease has largely been excluded from clinical trials, and it's not included in the risk calculations of the pooled cohort equations. It was difficult to know, but no single studies supported a systolic target less than 140 until SPRINT, and SPRINT included 28% of its population with CKD stages 3 to 4. So we have a lot of uncertainty up to this point, but we relied largely on the data from SPRINT, which were very compelling. And in this sub-analysis published last year, it showed that for the primary outcome, the hazard ratio was 0.72, and was identical for all-cause mortality in preventing cardiovascular events. So then I want to wind up with older persons, and here I think it's a difficult topic. We're not used to placing older people on antihypertensive therapy. In the past, we've even said that higher blood pressure might be better, but our recommendation with a Class A level of evidence is that the treatment of hypertension with a treatment goal of less than 130 is recommended for non-institutionalized ambulatory community dwelling adults who are over age 65 with an average systolic pressure at 130 or higher. And then for those who have a high burden of comorbidity and limited life expectancy, based on expert opinion, we're recommending clinical judgment, team care, and discussion with the patient and the family. So the data for these recommendations for ambulatory free living adults come from SPRINT. This is the primary outcome. This is all-cause mortality. They both showed close to a 30% improvement in benefit from cardiovascular disease prevention. And this was true whether the patients were fit, less fit, or frail, and was unaccompanied by a significant risk of falls or orthostatic hypotension. This is my last data slide, and this is a paper that was published this year by Josh Bundy, and is an analysis comparing the 2014 evidence-based guideline, which is sometimes called JNC8, in which the blood pressure recommendations were higher for both classification for threshold and target compared with our guideline recommendations. And so this study focused on two things: the incidence of major CVD events and all-cause mortality by modeling 4 community-based adult cohort studies, and then did an extensive network meta-analysis of 42 randomized trials to estimate the benefit. And the bottom line is shown here, that the annual CVD event reduction in adults greater than or equal to age 40 was 270,000 in the 2014 guideline, and is 610,000 with a number needed to treat of 70 in the current ACC-AHA guideline. And there were similar major differences favoring our guideline in terms of annual reduction of deaths. So I think, and there are other studies that have been published this year that show that the patients whom we had hoped and thought were those with increased risk in that 130 to 139 over 80 to 89 category that we were recommending for drug treatment actually have that risk. And so I think now it's a matter, or at least from my obviously prejudiced standpoint, but still I think it's a matter of implementation of these guidelines. And we've started by my going to my own doctor a couple of weeks ago and getting a BP true blood pressure measurement. And it was 134 over 70. And so he said, well, are you going to follow your own advice? And yes, so we started a small dose of candesartan. So thank you very much for your attention. We presented a new system for blood pressure classification, new thresholds for initiating antihypertensive therapy, depending on cardiovascular disease risk, and a new target for blood pressure treatment. Thank you.